Hi, everyone. So we're going to kickstart tonight now. Thank you for joining us, and good evening or good morning, good afternoon if you're joining us from elsewhere in the world. Welcome to our second day of the first ever ISOHA Europe Virtual Conference 2021. And if this is your first night with us, then welcome, and you promise an exciting week ahead. So we're really happy to have all of you joining us here tonight. So before we start off tonight, just a quick reminder again, that if you attend at least 5 out of 7 days of the conference, you will get a certificate of participation. And the way you can get your attendance recorded is through a link we will send out at the end of the evening. So make sure you stay for the entire course of the Zoom session, and we will post a link on the Zoom call, but also through our social media platforms. So don't worry if you missed out yesterday's attendance. I know some people didn't realize it. You still have 6 days ahead, and you can still get this certificate if you come for the rest of it. I will now cover some basic ground rules for the Zoom call. So please keep your cameras and your videos switched off during the entire session. This is just to ensure that the network stability is at its optimum and we can all hear each other better. If possible, could you please rename yourself on your Zoom display name? So change it to your own name and followed by any club or organization that you represent. It could be university, it could be the name of your OneHealth club. Yeah, because I know some of you have joined from your iPhones or your iPads and it just says iPhone, so it'd be nice to know who you are. During the session, feel free to put any questions you have for our speakers within the chat box, and we will then have a short Q&A after each presentation for you to have your questions answered by the speakers. And lastly, note that the presentation will be recorded and this will go up on our YouTube channel as well. So if you missed out on anything or you want to watch it again, it's all up there. So for tonight, we're really delighted to have 2 speakers. And first, we have Dr. Julie Garnier. So Dr. Julie is a dedicated OneHealth practitioner and veterinarian with 25 years of experience in community-based conservation and development in some of the most threatened ecosystems of our planet, with and for local indigenous communities. Following some innovative conservative work on black rhinoceros with Shangaan people in Zimbabwe, she developed a community-based coastal conservation program in northern Mozambique, which has since become a model for sustainability. Now, she's committed to implement gender-sensitive OneHealth in other local and indigenous communities in threatened ecosystems, and has helped to develop the OneHealth programs in Bolivia, Morocco, and India, just to name a few countries. She's worked for 18 years with the Zoological Society of London and has helped to co-found the Odyssey Conservation Trust with a small group of experienced conservationists and OneHealth practitioners. She's also the chair of a working group on biodiversity, gender, and OneHealth in the European Network for OneHealth and EcoHealth. Tonight, she will give us a presentation entitled Gender Responsive OneHealth to Help Heal Nature and Ourselves. We're very excited to have Dr. Julie with us tonight. I will now hand the time over to her. Dr. Julie, please. Oh, Dr. Julie, you have muted yourself, so you have to unmute yourself.
Can you hear me now?
Yes, perfect. Thank you.
Great. Well, good evening, everybody, or good morning, wherever you are. It's a pleasure to be with you today, and I'd love to talk to you about a topic which obviously is very close to my heart and has become a commitment. I'll just share my screen now. Responsive nature and ourselves. And I think, you know, we've been hearing One Health with the pandemic, and it's a really important topic, and we all in the middle of this pandemic. But I think I'd like to give a broader perspective to One Health, addressing nature and why we need to heal nature and how a gender responsive One Health could help us to heal conservation with and for local and indigenous people, which I believe are the true custodians of biodiversity and have an incredible role to play in protecting nature. And I'd like to show you how, these people really need support and how the One Health perspective is what we need. So to start with, well, we're all in the middle of this pandemic, and the COVID pandemic epitomizes the need for health. The latest figures are 90 million cases confirmed, obviously a lot more, nearly 2 million deaths. And everybody has realized now that a siloed approach has only allowed for being reactive to the pandemic. We're now acting to save lives. We're trying to do surveillance. We realized how limited and One Health perspective and One Health approach has become more and more an issue, and everybody is hoping that this will help us to deal with future pandemics. And an interdisciplinary approach will allow for prevention at all levels. We've been hearing about how the pandemic started, and I think we'll hear more. There is a WHO team at this moment in China to investigate how it all started, but maybe we'll never know how it all started. I think what's important is we've realized how limited our approach to health and nature has been limited and how we need to change the paradigm now. We've realized also through the pandemic that the data we've been collecting is fairly limited. This is data that sex disaggregated data that has been limited, that has been collected for the pandemic. I would recommend to go on this site, Global Health 50/50, which has got a very good grip on the situation. And the countries in red show that they are not collecting, or they've been collecting very limited sex disaggregated data. We realized very early in the pandemic that there seemed to be more men dying than women. And indeed, this seems to be the case globally, with 14 men dying for 10 women. This is a start to collect sex disaggregated data, apart from all the drama that is behind this data. But I think, we're not going to get a grip on the pandemic if we don't understand better the impact of the disease at all levels. So, for example, testing, confirmed cases among healthcare workers, hospitalization, ICU admissions, deaths. There is a realization that very few countries are actually collecting sex disaggregated data along these lines, So it's mainly death, case fatality rates and confirmed cases, which now are starting to show sex disaggregated data. But again, it's limited, it's not consistent, and it's definitely lacking, because to develop proper intervention, we need to know exactly who we're with and which are the most important group. And this leads us to understand, why sex and gender are determinants of disease. How are they determining this output? I would just start with definitions. We understand by sex the biological characteristics of a person, starting with her gene pool, her or his gene pool, and immune and endocrine system, anatomy, etc. So, for example, pregnancy is a vulnerable stage in women, and we know they're more prone to certain diseases like Zika, like brucellosis, like a lot of other diseases. We also know, the X chromosome, he's bearing a number of immune-related genes, and that seemed to confer women with a more robust immunity, both adaptive and quite innate. So, we suspect there is we know actually there is a protective role played by estrogens. But this doesn't seem to really come into consideration with COVID-19. Although recently we've discovered, some research teams have discovered that the ACE2 gene is on X chromosome. And obviously this is playing a role. in the fact that more men seems to be dying than women. But there is a lot of research happening now, which is absolutely crucial, because that would obviously impact the way we can develop treatments and vaccines. Now, on another aspect, gender is also important as a determinant of disease. And by gender, we understand the sociocultural defined constructs of male and females, which means, for example, norms and behaviors. For example, in some societies, behavior like smoking is more admitted, is more adopted by men. Roles and responsibilities of men and women in societies are absolutely crucial in disease, and I'll explain to you through the talk how. Basically, women have different roles and responsibilities from men, and it all depends on cultures and on the constructs that are borne by the society. Access to resources and services is also very important. In some countries, in some structures, in some communities, women will have more difficulties in accessing healthcare, for example. And again, I'll talk more about that at a later stage. Decision-making is also very important. Who is in power to make decisions? Again, inequities are going to be crucial in determining the way prevention and control of a disease are being developed and adapted and implemented. But it's both sex and gender which are going to determine how a person is vulnerable to a disease, how he or she is exposed to pathogens, and how she or he will respond to infection. And the combination of all these factors will determine the incidence, duration, and severity of disease in a person. But actually, you need to put it in an even broader context. Health outcome, we're seeing here. Well, health outcome is the result of both social and gender inequities. And what we're seeing is, starting at the beginning of life, an individual with its genes and body features and hormonal systems is going to go throughout his life through gendered systems, starting at the family level, community level, where behaviors, attitudes, and systems will determine his position, social position. And what you can see here is, race, class, age, ability will most often place, male at the top of the scale, and marginalized male and marginalized females at the bottom of the scale. And this is amplified with institutions, structures, and policy-making institutions, which are amplifying the systems as well. So at the end of the day, well, you have, as I said, gender difference in exposure, in behaviors, and you've got gender-biased health systems. The WHO has produced an important report a couple of years ago, which recognizes that actually the health sector is delivered by women and led by men. You only have 25% parity at senior level in global health institutions. Whereas actually the health workforce, we've heard a lot about it with the pandemic, and we're still hearing, the people at the front line of healthcare are mainly women. 75% of healthcare workers are actually women, which is why, WHO now and global health institutions are just starting to recognize the importance of gender, but there is a huge gap with implementation. We're far from seeing a change in attitude, and hopefully the pandemic will bring some change. So again, the pandemic has really the need to look at the interface, and that's what One Health is about. Well, when you look at wildlife and human interface, it's actually fairly small. Now, biomass distribution of land mammals on Earth only 4% of animals are wildlife. The rest is farmed animals, you know. So the interface is fairly small, and the most of the interface is with farmed animals. But nevertheless, you know, there's been an estimation that there are up to 850,000 undiscovered viruses with zoonotic potential. And as we saw, you just need one to create absolute havoc around the world. There's been a study amongst 140 something viruses, which has showed that actually it's mainly rodents, bats, and primates to a lesser extent, which are carrying these viruses. 75% of these viruses are carried by rodents and bats, which are actually very diverse orders. You know, you've got more than 1,500 species of rodents and about 1,000 species of bats. And these species have adapted to human-dominated landscapes very well. So the interface is actually there. And they're now closer and closer to households. They come to crops, and they certainly represent a risk. We've actually, in a recent paper, we've reviewed the publications taking the example of brucellosis, which is a professional disease, and which affects, as you know, the reproductive system. And we've reviewed all the literature dealing in recent years. And among the publications, there was only 1.5% of the publication reviewed which addressed health consequences on women. Considering that now you've got more and more women vets, it's actually a risk, and that needs to be addressed, not only for vets, but farmers also. There is a feminization of agriculture. More and more women are now taking these responsibilities, and we just need to evaluate the impact that these diseases, it's not only men, it's women, and it's taking a gender perspective to understand how people are affected differently. And then we'll be able to target, you know, and develop preventive and control methods adequately. But I'd like to take a broader perspective than just the micro lens on One Health, and just talk about the drivers in One Health, the drivers of biodiversity loss, because we've realized actually biodiversity is central to One Health. Just looking at the wildlife trade and consumption, we've talked a lot about it with the pandemic, and this has become, you know, an issue that people is talking about, you know. And indeed, you know, we have to address this challenge. There is nearly 1 in 4 species of wild terrestrial vertebrate which is traded globally, and we've got two aspects: the legal trade, which is huge, you know, which is developing very fast, especially in Asia, but in the States as well, in Europe, and it has been multiplied by 5 in 15 years, but also the illegal trade. And that is something that is really difficult to control, to evaluate, simply because it's undercover, and it's also associated with weapons and drug trade as well, even terrorism in certain areas. So it's really difficult to evaluate, control, but it's also, you know, for the legal trade, we need to understand that in some cultures, for indigenous and local people who live at the front line of biodiversity, who live with nature, and who've always used nature, and if there is wildlife in these areas, it's because they've been using it sustainably. Well, wildlife is also a source of nutrition. It's a source of subsistence. So I think there's been an outcry to say, oh, we must stop all trade of wildlife, you know, and we can't use it at all anymore. Well, we just have to be careful, you know. Maybe us, yes, in certain countries cannot have that, but, you know, let's look at subsistence of other cultures. And again, you know, in these cultures, we need to look at gender roles. You know, if we want to properly evaluate the impact of the trade, and we need to look at gender roles in wildlife use. You know, men are doing most hunting, trade, but in terms of use at home, you know, the women are doing the food preparation, which exposes them to certain diseases, such as Ebola. For example, in Ebola, it appeared very, well, not rapidly after some research, that, you know, men were exposed to start with because they were taking carcasses or they were hunting some primates. After a while, you know, women were more exposed because either they were preparing the meat or because they were caring for other family members who were ill. So again, we need a gender perspective, you know, in assessing wildlife trade, to understand its impact and to prevent disease emergence at the interface. Going on to the, you know, the role of local communities and indigenous people, well, you know, we have realized biodiversity needs to be conserved and restored. But what we need to really understand is that biodiversity can only be conserved with local and indigenous people. If you look at, there is not the map is not shown here, but there is a map available showing that actually indigenous people land overlaps with 80% of the world's biodiversity. And quite often these people have been removed from areas that their ancestors and that they traditionally owned. There is a human rights issue, you know, that also needs to be addressed, because you cannot just expel people from their land to access resources, mineral resources. And people, local communities, indigenous people are the true custodians of biodiversity. They've been living there for ages. They know their resources. Their traditional knowledge is actually huge. And we need to explore it and learn from these people to better conserve biodiversity with them and support them. But sadly, we see that actually local people living there are actually the poorer segments of society. They are, this map is showing, it's a very good study published in the Lancet, and it's been showing, you know, infant and children mortality rates and maternal mortality rates in indigenous communities. The vertical bars show, you know, the rates in the same countries for non-indigenous people. And you can see, you know, that MMR maternal mortality rates are much higher, up to 7 times higher than non-indigenous people, which means that to be a woman and to be indigenous, you know, makes you invisible twice, really. You cannot access, you know, any social services, any healthcare, anything. There is a huge social marginalization, which is linked to their geographic position. Obviously, people living in these areas live very remotely, but it doesn't mean they cannot access any form of healthcare or social services. There is also environmental degradation on their land, because quite often they've been expelled from their land and pushed around conservation areas where there is environmental degradation, when there is also human-wildlife conflict, where we'll see. And more importantly, for some of these people who have moved further to urban centers or to other places, there is a sense of biocultural dislocation, having lost, you know, ancestral lands, having lost traditional systems. And that is really important, because this is also a determinant of disease. And what we are seeing now is that this impact are going to be amplified by COVID-19. There's been a recent evaluation of the impact of COVID-19 on indigenous people. And actually, some people have realized, you know, that they couldn't access health, but they have turned back to some traditional forms of medicine and also traditional systems of, for example, confinement. So some of these communities have just locked down, you know, confined themselves using previous systems that were traditionally used by their ancestors. So this is a form of resilience. Again, you know, we need to learn from it. We cannot just ignore, you know, that these systems can be efficient in bringing solutions. Another aspect, of biodiversity loss, we've been hearing more and more about food systems and how they are a source, one of the main sources of biodiversity loss. Actually, the figures go between 50 and 80% of biodiversity loss is linked to land use change, which itself is linked to, food systems. And when we look at the diversity of our food systems, well, it's fairly poor. Today, we estimate that 50% of the energy, of our energy intake comes from only 3 staple crops: rice, maize, and wheat. Whereas actually, throughout history, there's been 7,000 crops which have been used by humans. And if you go back to the number of plant species, actually, you've got 250,000. So we're going from 7,000 to 3 main staple crops. We've lost completely the diversity of our food, which we need to reintegrate. And this is, this is part of the reason why we're seeing, that there is actually a double burden of malnutrition. But I'm sure, we've got a colleague which will speak tomorrow about food systems and One Health, and she'll detail all of that, I'm sure. But basically, food systems have produced health externalities, with a double burden of malnutrition, undernutrition with wasting and stunting. You've got nearly 200 million children under 5 which are either stunted or wasted. And at the same time, you've got an increasing number of children and adolescents and adults. Nearly 2 billion adults are overweight or obese, and the trend is increasing, as you know. And overweight and obesity are a significant risk factor for NCDs, which is the leading cause of mortality today. Again, we're seeing with the pandemic, this is also an increasing factor for of mortality suspecting, And what's also important is that women who are affected by either, undernutrition or obesity are perpetuating the trend throughout through generations. A woman who has been undernourished, in her early age, will tend to give birth to low-weight babies. And at the opposite, if a woman is overweight or obese during her pregnancy, her child is more prone to develop obesity or overweight at a later stage. So again, having a gender perspective is absolutely crucial when you're dealing with these issues, simply to be able to better prevent all these One Health issues. Gender aspects of malnutrition, I touched on it, but the global situation is actually pretty dramatic when you think that a third women of reproductive age are suffering from anemia. And this is going to be even more amplified by the pandemic once again, because women are shock absorbers in difficult times. In a family, we all know it, it's usually the woman, the mother, in difficult times, she will eat less food. She will try to bring more of an income. She'll do her best to support the family. Men will also do, but in terms of food and nutrition, women are absorbing the shock. And again, this has huge consequences on reproductive life and mortality, maternal mortality, since women with anemia during pregnancy are more prone to neonatal mortality and maternal mortality and low birth weight babies. So, this is a sort of transgenerational issue, and that has really to be addressed with a gender perspective. And we're also seeing that, women play a pivotal role in food production. They actually represent nearly 40% of the agricultural labor force and up to 70% in some countries. They've got a huge role. I'm talking obviously about lower and middle income countries and low income countries, but in some areas, in some countries, high income countries, in the countryside, you do have this situation as well, and they play a role in processing and distribution of food. And despite this crucial role in food production, they've got reduced access to productive resources, only 5%, land tenure 13%. This is a huge issue in lower and middle income countries. Women simply don't own the land despite working on it. And there is an issue of migration. Quite often their husbands are going abroad to try to bring an income as well. And still they don't own the land and can be expelled at any time. And all these gender roles in agriculture, also in water collection, in most households where there is no water, well, the role of water collection is devoted to women who can spend up to 18, 20 hours per week, collecting water. They also collect fuel, non-timber food products, which are all the fruits and other products, medicinal plants that you can find in a forest. And these roles are exposing people with risks. And I'm talking about now human-wildlife. And you live, at the front line of biodiversity areas, simply because now there is so much pressure on these wildlife areas, increasing human populations, very porous, and diffuse space, wildlife coming out of these areas, raiding crops, killing people in some instances. And I'll show you this example in Mozambique, where I did spend quite a lot of time, and we had a huge issue with elephant raiding crops. And you can see here a small water point that was used by people because there had been a 30 years war where actually people had been displaced. There was no water holes, no boreholes in the villages. And again, only women were collecting water. They had to go to these water holes to collect water, and they would go at more or less the same time. After a long study, we obtained the data that showed, how their movements coincided with the movements of the elephants. And here you can see the tracks of elephants going to the borehole as well. They were also, going to collect mangoes at the same time when elephants would go and eat mangoes. And both, there was competition for these resources, and that resulted in, quite a high number of deaths. And this is, conflict, this human-wildlife conflict is a huge issue in conservation. And I've looked at literature and actually, there is scarcely any mention at all of gender issues in human-wildlife conflict, whereas, it is clearly a gender issue. And I've lived there long enough to know how important this is. So when you look at figures, 3 billion people lacking access to clean water. Well, it's not only obviously around wildlife areas, it's around the world, but, is raising the issue of now, the structural One Health and how we need to develop, access to water, access to sanitation all around the world in the most deprived communities where there is no access. So women in these communities, local and indigenous communities are entangled in poverty cycles. And this is a picture of, what's that? This is a picture of a tribal woman in India, in Kerala. These people are so marginalized, hardly any people go and visit them. I went to see this community with one doctor who was going there from time to time. And there is clearly just a complete marginalization of these people. And there is a poverty cycles because there is marginalization, no access to health, no access to proper nutrition, and equal access to education. Even, for example, in that case, tribal kids are marginally going to school, but they're not really welcome there. There is also a huge burden of unpaid care work. burden of domestic activities, no time, no opportunities to have an economic life and bring an income, and an equal access to healthcare, as I mentioned, especially reproductive life, you know, which is really bringing people, as I said, you know, the transmission through generation of poor nutrition and poor health is really important, and women are just entangled in this circle. And the projections are not good, you know, especially with the pandemic, because the poverty gap is going to increase. And in 2021, we'll see what happens. But the projections that are 60 million women aged 25 to 34 compared to 54 million men will live in extreme poverty. Sorry, here we go. So I've insisted on the gender roles and responsibilities in communities, because what you need to do is to analyze all these gender issues and find how to identify an entry point to develop One Health programs that will create a lot of synergy and have an impact. And this is a project in Bolivia, which is with Takana people, about 9,000 people living around the Madidi National Park, which has got some of the highest biodiversity in the world. And to start with, you know, there is some human-wildlife conflict with jaguars, but with also birds of prey, which are preying on, you know, all the small livestock that women keep. And women had just such losses in their poultry and small livestock that it was not sustainable, and they were spending a lot of time just looking after their animals, and couldn't, you know, have an income or even, you know, proper nutrition. So we developed a project with organizations there, and going through the Takana authorities, traditional authorities, they identified talking for a long time with the women in the communities and the men, obviously. It's, you know, having a gender perspective means addressing both men and women's perspectives. But, you know, the women clearly identified their priority issues. They wanted to improve, you know, the productivity of their small livestock. They wanted to see some reduction in human-wildlife conflict. They wanted also to restore a traditional weaving activity, which is very interesting, because as you can see here on the corner on the left, you know, the weaving patterns are actually women's property, and they epitomize a relationship that Takana people have with nature, and this is a jaguar footprint. And it was very important. The women wanted to revive that tradition because it was a symbol of their relationship with nature. They wanted to really claim strongly that relationship mattered to them so much. And also there was, you know, women have the incredible ethnobotanical knowledge about medicinal plants and aromatic plants. So we developed a project little by little, which had different components and which allowed to improve, you know, the productivity of the small livestock and improve nutritional status of women and families, because, you know, by improving veterinary management and improving also protection of the livestock against, you know, human-wildlife conflict. And also, you know, we helped women to transmit and pass on ethnobotanical knowledge by encouraging them and supporting them to develop small horta, which is their little vegetable garden, which had, you know, all the plants that they could use also for medicinal purpose. And also we support them in restoring this weaving activity, which allowed them to have an income and also to have some autonomy, obviously financial autonomy, but social autonomy, which was really important. And what you can see is really One Health is about linking all these components. It's not only health, it's livelihood. It's not only livelihood, it's also pride of people and restoring, you know, or conserving their biocultural heritage. Well, that notion of biocultural heritage is very important because we know that if a culture goes in this area, the nature usually goes as well. And there was a very interesting, unexpected output of this program, which was the restoration, the revival of the Takana language, which was being gradually lost through generation. And there were a lot of workshops organized between women of different ages, weaving workshops. And little by little, the older ones started to talk more in Takana, teaching the younger ones who were gradually losing that knowledge. So you can see, you know, a lot of interesting synergies happening in these projects, which are holistic and which really integrate, you know, a holistic perspective. So One Health really is interdisciplinary collaboration at all levels, you know, starting with communities, and I explain a bit later, businesses, institutions, governments, where you've got gender inequities at all levels. It's really about preventing risk at the interface. We talked about zoonotic diseases, human-wildlife conflict. We talked about, you know, NCDs and malnutrition. But I think really at the core of One Health is the conservation and restoration of biodiversity. And that involves sustainable use. We cannot envisage biodiversity conservation with, you know, some use, especially for local and indigenous communities, which have always used their natural resources. And what is more and more talked about is also regeneration of biodiversity, which is happening more and more. But I think in order to be able to do all this, we need to reframe our production and consumption systems. And obviously we're talking about food, but we're talking also about energy. And at the heart of that is our relationship with nature. We need to be more humble and respectful. And I'll go on to a framework which we've developed, which is how really integrate a broader gender responsive One Health to help heal nature and ourselves. And this framework is actually not complicated. It uses a leverage points perspective, which is something that you can use in complex systems to address sustainability. Basically, you can see on this line, you know, if you action this lever, you will have more impact than this one, and than the ones over there. So the stronger lever, is really the vision. We need to change our vision. We need to change going from the pursuit of GDP and overconsumption towards a focus on well-being, a focus on reconnecting with nature and biodiverse and functioning systems, which I mentioned, conservation. And that will bring sustainability and resilience. We need to also amplify this, bring gender equity to leadership, and also respect. We can achieve this if we go through all levels of policymaking, businesses, institutions, civil society, to mainstream a gender responsive One Health. And that implies for policymaking institutions, businesses, research institutions, to really evaluate the risks, the opportunities, the obstacles with a gender perspective, you know, and with a One Health approach. So it's quite a big task, but not impossible. And at a civil society level, you know, we're seeing more and more awareness on, you know, conservation issues, on, you know, the risks that people have, and we need basically to reduce the risks, secure the rights, and bring a fair access to natural resources and landscapes, land tenure, water, healthy food, clean air, energy. It's an ambitious task, but I think, you know, now that there is momentum for One Health, it brings hope. And I think that's really what matters. I would go back to really learning from and respecting traditional knowledge and worldviews. What really brought my attention is that there is a sense of oneness in some traditional indigenous communities. And I think now that we are trying to develop One Health, actually we're not inventing anything. Let's learn from people who have understood the concept and who have been implementing it for generations and who we can learn from so much. So I'll leave you to think about this. There is more information and a lot of references in this paper, and I'd welcome all your questions now. Thank you very much.
Thank you very much, Doctor. Thank you very much for your presentation. Now I can read the questions for the session, question and answer. And for the first, I have a question. How gender inequality in education affects, if you can tell us something, or...
How gender inequalities affect health? Well, you know, gender inequalities at all levels. You can have, for example, access to health. Like, for example, in India, some women will have difficulties in accessing healthcare for cultural reasons. You can have, as I explained, gender roles and responsibilities. Women who are going to go and fetch water, you know, are going to be more exposed to some health risks. You can have waterborne diseases, but you can have also human-wildlife conflict, like I mentioned. But just, you know, with the pandemic, we're seeing, you know, 70% of healthcare workers are women. And this is a huge issue because women are then found, you know, to have to deal with all the other issues, you know, keeping children at home, doing homeschooling, you know, not being able to, from time to time to go back home because they've been exposed to COVID. So the gender affects health throughout, you know, throughout life, throughout your work, throughout your activities, throughout your culture. It's really, I think, going back to that framework, the first framework that I showed, you know, how gender systems are affecting health outcomes throughout your life.
Thank you so much for your answer. And in the next we have from Ace Spitzer. If women think that traditional economies and culture promote gender equality, how does any Western-centric concept of economic development promote that economy?
Sorry, can you say it again? Can you?
Yes. If women think that traditional economies and culture promote gender equality, how does any Western-centric concept of health or economic development promote that economy?
Well, I think it depends on political leaders, you know, and how we're seeing, for example, a very good example with, I'm not saying that all political leaders should be women, but there need to be gender equity in policymaking, you know, institutions and in governance. And there is a very clear benefit from having gender equity at this level. Well, you just see, for example, you know, the ultimate example of, you know, having a prime minister with New Zealand, you know, which is now adopting, you know, a different societal model where, you know, health and well-being of people is really a focus and an objective, and that's happening also in some other countries. So if you bring women's voices and perspectives in policy making, you know, you will have, you know, more equitable access to health, and you will have more, you know, more impact on all these issues.
Thank you so much. In the next, Dr. Ali Halajian asked if I understand fully that women are more impacted, as said, but I believe empowering women not an easy job, as what if they don't want to be empowered? What if their men partners resist? Look at teenager pregnancy in Africa, nobody forcing the woman for that, but they are impacted and improving. That is so hard slowly currently. Your advices, if you can give us some solutions.
Well, I think, it's really having fair access to reproductive health, maternal health is paramount to health equities. And in Africa, it's not so much, maybe in some places, women don't want to benefit from maternal and reproductive health, but in many, many places, women will really want to benefit from it. So I think it's really, being able to deliver health to all communities, the most remote communities, explaining people know, a woman doesn't really favor, in Madagascar, in some stages you have, women having up to, 10, 12 kids, it's not because they really want to. I mean, and there's been projects which have been implementing, maternal and reproductive health, and it has hugely benefited the community. The women were desperate to be able to access such health care. So I don't think it's because they don't want it, it's just because it's not there,
Thank you. Natalia Margarita is asking, it's saying that she agree with you into this matter of gender-based One Health, but her question is if she knows any work done in Latin America working with climate change mitigation with gender focus.
Yes, I'm sure there are some examples. I mean, I don't have any coming to mind now, but gender focus in climate change is becoming really bigger and bigger. And I think, I didn't mention it so much because I think, there was so much to say about health, but I can find out, but there are some examples, yes, in reforestation, in, also learning from traditional knowledge in climate change, mitigation. There are some examples, whereas in forest ecosystems or coastal ecosystems as well, which is an important issue in climate change mitigation.
Okay, thank you so much. And last question from Bamlak Kazahun. I am Bamlak. My question is, what do you think about or what will happen if we are not really consider One Health in every single activity, or what will our universe look like without One Health?
I'd love to be able to answer, but I don't think I can. I think we just need to put all our chances on our side, and just, as I said, reframe our relationship with nature. I think, it's just needs to, we're not at the center of nature, nature can live without us. We can't live without nature. That's, so the end result of all these crises we're facing, nobody knows the outcome. I'd love to, but I can't say.
And to what extent has gender issues been integrated in the One Health framework?
Well, not so much really. There's been some developments in addressing emerging infectious diseases. So there are frameworks to integrate a gender perspective in, infectious diseases, but not so much in the broader perspective of true One Health. which is environment, biodiversity, health, and having the human-animal environment interface, really. So there has been some developments, and I think it is, being promoted, but not with the true biodiversity perspective.
Thank you so much.
Thank you so much, Dr. Julie. I think that's all the time we have now for any questions, but I think a few of the participants have requested that you put your email just in the chat if you like, because I think some of them have private questions for you. So, but also if anyone else has questions for Dr. Julie, just put them in the chat and keep them coming. We will compile them in a separate email and we will give your questions to Dr. Julie so she can answer it at her own time. But thank you once again, Dr. Julie. That was truly an insightful presentation. I think it truly encapsulated what One Health means when you bring in, not just health issues, but things like gender and where people are from and food systems and things like that. So that was really amazing. Thank you.
Great. Well, thank you very much for your invitation. It was a pleasure. And yeah, don't hesitate to be in touch for those who want.
Yeah. So Dr. Julie will put her email in the chat, so keep a lookout for that. And for tonight, we are very lucky to have a second speaker with us as well. So yeah, if I would just cut off the screen sharing thing and hopefully we'll put mine up now.
Very good.
Perfect. So tonight we have Dr. Veronica Omier as well to join us. So thank you for being here with us, Dr. Veronica. Dr. Veronica is a veterinarian from Peru. She's also the co-chair of the One Health Social Science Initiative and a member of the One Health Latino America. And tonight she has a presentation entitled "Why a Veterinarian Would Be Interested in the Social Sciences and One Health." So I will now hand the time over to Dr. Veronica.
Thank you, Sam, and thank you, Maria, also and Andreas for the invitation and for the great presentations that have been happening yesterday and today with Dr. Julie, and with the presentation that you will have during the week. I think you will gain a lot of knowledge and maybe questions that will arise. Let me see. I knew how to share. Okay. This is here. So, Sean, can you confirm me that you can see it?
Yep, we can see your screen. Perfect.
So I will put it bigger. Okay.
Yeah, that's great. Thank you.
Thank you. So, well, good afternoon, good evening. And in my case, it's also afternoon because of my location. As Sean said, my title will be "Why a Veterinarian Will Be Interested in Social Science and One Health." And I really want to present you not a scientific research, but mainly my experience towards the One Health approach. I'm still on the path, and also how I got involved in the social science movement and my interest in the social science part. Well, yes, I'm a veterinarian, and I am also part of the One Health Social Science Initiative and a member of the One Health Latin American Caribbean group that I will talk about later. I will start how I got interested in One Health. And I think I can blame my tutors and mentors, our professors, because they put the flame of these great courses like parasitology, infectious diseases, public health, epidemiology. I love those courses. And in those courses, we have the opportunity to go to rural communities and listen to the problems that the communities had, especially to see how the animal health was, if there was in a good management or in a wrong management, and also if the communities were having problems with health diseases. Later, because of this interest in these courses, the last year of the career, we have to do an internship. I think every veterinarian in the career has to do this, no? for us in my country, that is Peru, we had 10 months which you can practice in one place. I choose some months to spend in the Institute of Tropical Medicine, Alexander von Humboldt, and as you can see in the name already says tropical medicine. We call it tropicales, that is in Spanish. There, I knew mentors that were medical doctors and also biologists, biotechnologists that were experts on the field, especially on the field of neglected zoonotic diseases. Let's say, whenever a case that arrives, it will be especially for fasciolasis, echinococcosis, or another helminths parasite. I didn't saw so much cases of rabies because for rabies there are other organizations in Peru. But here it was mainly those diseases. And brucellosis, very few, but I also had the opportunity to join for vector-borne diseases studies. So it was a great interaction between medical doctors and veterinarians. I have to put that because as ISOHA, I guess you are looking on how can I grow my interest on One Health, no? And in my case, until that moment, I didn't listen the word One Health. It was just this passion for me of the courses of undergraduate and also this interaction with the mentors. When I was there also in the internship, they were forming a toxocariosis working group. I don't know if you remember, or maybe you know that there is a parasite called Toxocara. It could be Toxocara canis, Toxocara cati, which affect dogs, obviously if it's canis, and cati if it's feline. But it is important because it is a zoonotic parasite, and in some countries, for example in my country, it's a neglected zoonotic parasite. It could affect people, especially children, and in children it can cause severe damage in eyes because it can get cysted there, in the brain also, so affecting visual learning. So when I was there, I was, oh, this is really special for me, toxocariosis and working group, how can I get involved? And one of the doctors said, Veronica, why don't you work in your dissertation thesis about toxocariosis? And if the people know preventive measures and if they know what is toxocariosis. And why don't you take a population of school children and their parents? And I say, yes, but this research project has a background that I will explain in the next slide. So for the dissertation thesis, as you see, there is the title, a big title, and I put what I learned there. I learned that, and I will repeat it later, the need for education in neglected zoonotic diseases, the importance and the impact that they had in children and in vulnerable population. And also I was wondering, do we need a curricula and education in neglected zoonotic diseases, especially in school children? Later, still in that time, I didn't listen the word One Health. Later, when I did my master's degree in Wageningen University, where I gained a scholarship to study the master, almost finishing, because I did my master in epidemiology, almost finishing, I listened the word One Health. And obviously there was an interaction between a lot of professionals, also the professors. I also received courses of plant health. So there was the notion there. And when I finished, the concept of One Health arrived, and I say, oh, I really like this concept. I want to follow it. And then thanks to life, how to say, I won another scholarship to study 10-month program, another master degree in the Institute of Tropical Medicine in Amber, Belgium. And then I did my thesis in One Health education in Peru. So that was an opportunity for me to really set the basis of what is One Health, especially in my country. So coming back to the research thesis on how this started and how I found that this is the undergraduate thesis. Parasite and this approach can be a One Health approach. As you may know, the One Health approach can be seen from different areas and different views. And that is also a very valuable point. My research thesis, this is the undergraduate thesis, was performed in the most populous district in Lima, Peru, which has extreme poverty and had a zero prevalence. Look how much is the zero prevalence, 46.5%. That is in 2007. Actually, there must be more seroprevalence studies in toxocariosis. So that I put this data because those were the data that I took to perform the thesis that was in 2008, 2009. So actually you have to come back a little bit some years before. So again, look, the most populous district, poverty, zero prevalence, high prevalence, almost 50%. In school children, look the importance of that. And also the contamination of parks of Toxocara canis. It was 70.6%. After this research appeared, the one of 2007, there were more studies on Toxocara canis in Lima, because Lima is the capital city of Peru and is really big. And also Toxocara canis is a parasite that can be seized in the parks or in vegetation and will prefer cálid or warm climate. So in this case, just looking this first paragraph, you can see that might be a One Health approach, no? People, the seroprevalence that is high in children, vulnerable population, and the contamination in parks. But still, we didn't know the concept of One Health. For the thesis, for this research thesis, we use this educational material that is there in the graph, where you can see that there's a child washing hands, playing, and the veterinarian. And we use it because there was this research thesis was part of a project from medical doctors that were doing the seroprevalence of toxocariasis in children. And they made several health campaigns to schools in this district. So in order to have these health campaigns, they made this flip chart or educational material, and I will use it later for the research questions. So again, the big picture of the flip chart, the importance of washing hands, that the parts can have parasites, maybe in the faces, the importance of veterinarians when there is a treatment for animals, especially in this case, dogs, and the importance to have a responsible ownership, obviously picking up the faces of animals. If you are interested, even though it's in Spanish, but the abstract is in English, and it's in 2011, this study, you can go and check it. It's really nice. So this informational material caught my attention, and let's say, okay, let's work on this thesis and let's join the group. My objective was to evaluate if the school children that participated in the seroprevalence and the ones that listened and attended to these health campaigns remember 3 years later what were the disease. Let's say if they remember Toxocara canis, if they remember they were preventive measures. For this, I'm putting very shortly that I use a survey, and I included school children and their parents that follow this health campaign in 2006 with the flip chart that you show, that you saw. And also I compared it with another group that were new students that arrived to the schools. I have the data, and obviously all the study passed the ethics committee. directly, some results, because I had some other slices to connect you with the idea of social science and some activities that we are doing in OLAIC. So directly I go to the results. What the children and their parents respond. Actually, there were no significant differences between the children and their parents that listened to the flip chart or attended to the flip chart and the new ones that arrived. So we were guessing, okay, maybe the new ones that arrive because they are making friends with these old students, the old students can have passed the information, maybe TV, radio, or another health campaigns have been done in this location and they have gained interest and knowledge. There were a lot of questions there, but yes, more studies have to be done on this, no? So what were the important answers? The children and their parents respond that diseases from animals can be contracted in parks. They know that parks can be not harmful, but the faces of the animals can have parasites or other, let's say, they didn't call it pathogens because we are talking about children, but they related that they can get disease. They also affirm that the pet faces can have parasites and that they even saw it. They also suggested that they have attended to parks where they saw restes of animal faces and some faces have parasites. What was really interesting was that they mentioned that veterinarians, parents, radio, or TV are the ways to get informed about parasitic infection. So we were guessing that these ways of acquire knowledge are really important because maybe they are trusting in the veterinarians and also obviously in their parents on the quality of information they receive. One point that is really important, they mentioned that they vaccinate and wipe their animals regularly, but when you ask them if they, what did they mean about vaccination and wiping, they just remember the injection. So they don't differentiate. And what was a really good point was that they really understand the need for washing hands after playing with the pet, after going to the park, after going to the toilet, and before eating. Please remember that this study was done when I was undergraduate before getting the graduation. But I really noticed, and I think I put it here, yes, I really noticed the importance of service, especially this connection between school children and their parents and the communication they can have. And what kind of message do we give them when we do health campaigns? Again, these two graphs that are in the upper side, that is the educational material and the cycle of Toxocaracanis are not mine, are from the study of Breña, which is from where I base some of my research. And again, for this, what I learned, children are the most affected when we are talking about neglected zoonotic diseases, education in zoonosis, obviously because I'm talking about this topic, but education in general must be frequent. So children, they just learn quickly and they acquire the knowledge quickly. Children and their young parents, I said must work together, but okay, they might be working together because there is a strong connection, at least one of the parents. And surveys are fundamental to understand what, to have a clue what people understand about the disease. And then this was done in 2009. Last year, we also have a webinar, which I will just point at you again, where this is also a statement that I confirm. And then I can say that Toxocaracanis can be a good example of the One Health approach because it involves animals, especially this connection with the dog, the environment where it has to evolve, and the human. What were the next steps? Because as I said, I didn't listen the word One Health after I finished my master degree, and then I did my master degree, one of my theses in One Health education in Peru. I said, where can I join? And I think this might interest you. I joined the One Health mentorship program when in 2019. Actually, there is a point in Peru there, and I worked with a Nigerian veterinarian, which I put here, which her name is Dr. Kikiope, and I just talked some days ago. Kikiope, can I mention you in this ISOHA conference, because they might interest the students of the conference, and she agrees. So what I want to say, that this ISOHA mentorship program was a good opportunity for the interaction, for discussing problems of different countries, because I'm Peruvian and she was from Nigeria. We have to schedule times. Sometimes we talk via email, and sometimes we talk via Zoom or Skype. And I think there was 5 months in which we discussed what were our objectives. We said, okay, let's discuss what are similarities or differences that we found in infectious diseases. And she was also interested in the social part. Actually, she has been working on the social part. And after we finished the ISOHA mentorship program, some months later, she mentioned that she was developing a One Health development initiative, as you can see there. I invite you to visit her page. She is really open to international people, international students, and I think it will be a very good opportunity for you as students to discuss with her. Sometimes, no, not sometimes, actually, normally you can see that there are vacancies and information that she and her group developed in this page. Later, I also joined the One Health lessons with Deborah Thompson, and I really was touched with her work and with her passion of the One Health lessons. So I raised my hand and said, I can volunteer for the translation in Spanish. What I found was a really organized program, and I also found that there were volunteers there from any part of the world. And also it was really important that the lessons were for One Health and COVID and for children. So for me, it was a really good experience. And I think you also have Deborah in this week. So join. I know you will join because she has really good experience on this platform, on the One Health lesson. Then I also joined the One Health Social Science Initiative and One Health Latin America, which is something that I will talk now. I want you to see, or at least to give you the feeling that my interest started because I saw that there were vulnerable populations and how to approach them and how to understand what they understand. I am not a social scientist, I'm a veterinarian and also lecturer. I love physiopathology, pathology, infectious diseases. That is something that I normally do. I have also been involved in biomolecular projects, let's say like this, but not really a main project in social science. I have participated in some few, and those gave me still the feeling that I want to continue on that road. But from the moment, as you can see, One Health means working in teams, and working in teams will involve that you will meet people from different countries, from different cultures, from different initiatives, maybe temperament also, and ideas, which is really nice because for that you can get a really open-minded and discuss what are your future projects. For this, I will talk about the One Health Social Science Initiative. If you want to know what we are doing, you just Google One Health Social Science Initiative and you will see that we are under the One Health Commission because we are part of it. There is the photo of the four of us, that is the leadership team. And just recently in December, we launched a call inviting a new member. So this week or the following weeks, you will get to know who is the new member for the One Health Social Science Initiative. Let's say these 4 people are the ones that we really want to work in the social science part and initiative and to include this social science part. For example, Bernardo, who is Mexican and is a medical doctor, he has this connection between medical doctor and anthropology. And Elena, who has really good experience in Dominican Republic and also speaks in Spanish, and she's really, also all of them are good friends, give advices for the One Health and the experience. No? Elena also has experience with GeoHealth, and Laura, who has experience in public health in partnership, you will see later. So very shortly, what is the mission of One Health Social Science Initiative? To include this or incorporate the concepts and methods of social science in the research and work of One Health. Obviously, as you can see, there are papers already that are mentioning One Health and social science, which is really good, and One Health and other disciplines. So I will go directly to what are our actions that we have been doing in these years. For example, we provide a platform for collaboration. And we do this with regular meetings, presentations, and also opportunities for networking partnership. We look for communication, dissemination of information in forms of webinars, and we have a video library in English and Spanish. We still have the aim to include another languages. We have on paper already some webinars in mind for Portuguese that we will invite. There is also a mapping project that you can Google One Health Social Science Initiative and you will see it. And also another project that we have and is under construction is the website of One Health Social Science Initiative. We also have this coordination to offer opportunities for engagement. We will form working groups, we look for publications and presentations as the one that you can see in your right side, where last year in September, we presented a poster on the activities that we have and how they can connect with the Sustainable Development Goals. It was for the IX, that is the International Conference of Sustainable Development. Let me see here, yes. So, we just put some photos of the flyers that we use to promote the webinars. And as you can see, from 2018 and to 2020, we have network meetings in which we discuss, we gave a short webinar and we discussed your opinions and questions and views. And we also have webinars, in total 18, and you can see the numbers there of attendees and the video views. If you still want to listen to them or to view them, in the next slide you will see where to go. Some flyers here. We had different topics. For example, one of the topics was One Health Social Science in the Amazon, where there was an expert in economics and politics working in the Amazon. And also we combined it with a veterinarian that works in the World Conservation Society. She spoke about illegal wildlife trade in the Andes communities, in the Andes Amazon countries. We also invited Deborah for her good work with the One Health lessons. We also included some this flyer for One Health Latin America, where they spoke about welfare. This was in Spanish, and we will also, as I said, include other languages. And as another example, there was also an important part of education, in this case with Dr. Rohini, with the interprofessional education and One Health, and how these MDs and veterinarian students can interact. These are all the webinars that we have given. In total, they were 18. As you can see, they go from the most recent, let's say. They go from, look, anthropology and One Health in natural history, education and One Health, understanding the wildlife trade. We also have a discussion for COVID-19 and one of One Health's perspective in wildlife trade, social, cultural, and political states with Dr. Laura Kang. And last year in 2020, we had Dr. Severine Thijs, who is a Belgian doctor who her degree is in anthropology. And as you can see in the title, the added value of anthropology for integrated control of neglected zoonotic diseases in One Health movement. And I don't know if you remember when I was talking about my research thesis there for the undergraduate time, she made me notice that still surveys are really necessary to understand what people, to have a clue of what people understand about diseases. And then you can also see that there are other topics. If you want to attend, to see them, just go to the One Health Social Science page and you will see this table, and they will send you to the GoToWebinar, or maybe sending a link, an email that I will show you later. We also have activities for partnerships. For example, some of our members participated for this global survey with the One Health European Young Program. We also have connection with One Health Latin America. And also, one of our members is working with the Rural Water Initiative for Climate Action from Uganda. So as you can see, again, One Health is working in teams. One Health can also be this partnership agreement and friendship sometimes. Okay, I see that the email doesn't appear, but if you enter there in One Health Commission, you will see it directly our email in case you have any question, no? Our future steps and activities, as I said, last month we launched the call for a new member of the One Health Social Science Initiative, but we will still communicating more activities for this year or for the coming month, because we want to get people involved in this movement, and especially you as students might have the energy and enthusiasm to work on this path. And then I will talk about One Health Latin America, which is the other group that I'm a member. Again, One Health, and in this case, One Health Latin America, is formed with different researchers and professionals from a lot of countries. And founders of this group are Dr. Daniela Figueroa from Chile, as you can see, Dr. Juan Carlos Carrascal from Colombia, Doctora Juliana Gallardo from Brazil, Doctora Cristina Pretan-Brewer from Brazil, and working in University of Washington, and me in Peru. But actually, the work that I will present you from that is being done OLAIC is not done for these 4 people. Actually, there are more people involved, and there are coordinators that actually they are the motors of this group, the energy of this group. As you see, there is a collaborative, pro-social, and integrative work, and the coordinators are divided in research area, education, international network, and marketing, which means how to make promotion of One Health between the networks, different networks that are available. Please look at the names, make your research if you are interested. As I said, and I continually say, One Health cannot be done by one person only. The mission and vision of OLAIC, and I think as you can see from the presentation, is to act in form of collaboration, synergism, and also not competitiveness. What I really like from her mission and from the mission and vision here is that they say union of cultures and thoughts for the initiatives around the One Health. Yes, because as you can see, and maybe you know, Latin America has different countries, have different cultures, have different languages also, and between the countries they have different dialects, and even in a country like Peru, we have different behaviors in departments and districts. So imagine all Latin America, no? Which is really and super interesting because it helps you and makes you creative. How can you work on One Health approach in Latin America with so many countries? The proposal for One Health Latin America is educate, increase the notion of One Health and the promotion of researchers in LATAM, reduce this working on silos. Maybe you have listened to this. Carry out focus group and workshops and promote empowerment and a healthier international relationship in the countries of LATAM. As you can see, normally when you are forming groups, you will then get friends. There are commissions also in One Health Latin America, which are divided in vector-borne diseases, rabies, education, antibiotic resistance, neglected zoonotic parasite, foodborne diseases, which helps to include and direct the people that is interested in One Health. Obviously, if you like everything, you will be in almost all the commissions. I wanted to present you this because this was a really good opportunity for some researchers in OLAIC because they participated as topic editors for Frontiers. The topic was challenges and successes of One Health in the context of planetary health in Latin America and the Caribbean. Well, just yesterday, the submission of the articles was closed, but I think it was a really good point to have, or a really good opportunity to have them as topic editors. And also, OLAIC has won a project grant directed to thematic networks. As you can see in the blue arrow, we have the PI here, who is the founder of One Health Latin America, who is Dr. Daniela Figueroa from Chile. And this thematic network is about One Health against climate change and biodiversity loss. So stay tuned to know how we are working on this and who might be the researchers who are working on this part. Also, I will not go in detail for all the presentations, but it's just a way to show you that when you have a big group of people, you will have also a very good interaction with workshops. As you can see, there are, these presentations are from 2019 to 2020, and more to come, because here also I put the big flyers that were organized by OLAIC. I think it was really important because they were in relation to COVID-19. I was thinking if that was the, let me see, no, if that was that date, but yes, April and July. So you can see that we also got, we also want to share with you that Latin America can also be in harm or in risks for some pandemics, or how One Health approach or welfare can be an opportunity for COVID-19. they are in Spanish, but maybe if you are interested, you can also Google and contact the researchers that they spoke, because I guess they will speak, some of them English, most of them will speak English. And then just coming to the end, One Health Latin America also have partnerships. And in this case, they have a group that is called the One Health Civil Society Community, where they do activities to the community, health campaigns, health awareness campaigns, with children and families. And if you want to know a little bit more, you can just Google, the directions are in the last slide. One Health, Colombia, Brazil, and Chile, who are the ones that are having more experience of this. Some of the experience that I have heard, because of pandemic, and also I haven't gone to Colombia, but some of the experiences that I have heard is that they use theater, games to include children and parents and to explain diseases, which is really good in ways to learning. And also there is a One Health Latin America for students group that is part of the One Health Latin America. So here are the slides, the links if you want to see what are the activities that are doing in terms of OLAIC or the subgroups that have OLAIC. Also they have Instagram. And I hope that with this long, not so long presentation, I gave you the taste of how a veterinarian got interested on One Health and a part of social science, even though I am not a social scientist, and also how to build partnership with other people that is interested on One Health. Thank you very much. And now time for question, I think, Sean?
Yes. Thanks, Dr. Veronica. I'm going to let Maria handle the question and answer. So Maria,
Thank you so much. Thank you so much, Dr. Veronica. Thank you so much, all of you, for participation. And I will start with the last question from Professor Stroud. She is asking, the Global One Health community receives the Commission's monthly One Health Happenings newsletter that provides an overview of One Health news from around the world. So here is an interesting link, and we can share it.
No, I think, so that was just Dr. Cheryl, who is the director of the One Health Commission. She's just shared a few links through the chat. So if anyone's interested in some of the things that Dr. Veronica has said and mentioned about the One Health Commission and the One Health Social Sciences Initiative, do follow it and sign up for the thread. I think one of the questions we had earlier was from Dr. Ali. He says, Dr. Veronica, in Peru, do you have dogs or cat-proof fence areas in the parks for kids? He says that this is probably a cheaper approach than deworming for all dogs and cats. I think this is in relation to your thesis on Toxocara.
Yes, I'm trying to find where is the question. Can you help me? Yeah, let's see.
I will just copy and paste it again in the chat. So I've posted the, because I think there was a lot of messages.
Okay. Do you have dogs and cat-proof fences areas in parks for kids? Guess this is much easier, cheaper approach than deworming. There are some districts that have these fences areas in parks for kids. Yes, but not so all. And also when I did this study, when I asked the question how many dogs they have per family, normally they can have 5 or 6, and dogs will live outside. But obviously that was in that time. I'm talking about 2008, 2009. There is not so much difference now. As I said, there are differences in in cultures between districts, even in families. So yes, it could be a good idea.
So I don't see any more questions at the moment, but I have a question for you. So if anyone else is, thinking about your question, just use this time to put it in the chat box. But I just wanted to go off again on that same idea. I think you mentioned in your presentation earlier that, veterinarians are an important source of education for people, in relation to how to avoid diseases and things like that. So because I know you work a lot in the social sciences in the One Health aspect, based on your experiences, how do you think like veterinarians in practice, so in clinical practice, how they can play a better role in helping us with this One Health approach and sort of reducing diseases with pet owners and with just people in general?
For example, this research, the children especially, and the mother normally, they mention that when there is when her pet or its pet is sick, they will directly go to veterinarian. So there was a really important part for the veterinarian work. They really know it. From my perspective, how I see it, and I think some veterinarians do it, if not all, because they understand the need for public health advice. Every time you go to clinics, the veterinarian must speak what are the harms, risks, not risks, but let's say that you have to follow a controlled ownership of your pet, a very responsible ownership. And when I said responsible, it means you have to vaccinate it, you have to wipe it, how many times you have to wipe it, how many times you have to vaccinate, have a calendar. I think that is the responsibility for the veterinarian to talk with the patient when the first time it arrives, and the second and the following times it will visit the clinic. But also not only in the presence of clinic, but in other times. In my case, and I think some of my colleagues do also, every time that there is a conversation and it involves public health topics, I will definitely mention toxocariosis or neglected zoonotic diseases, because I have seen how people coming from highlands have a bulging abdomen because they have fasciolasis or echinococcosis or neurocysticercosis, for example, that cause harm in brain.
Thank you very much.
Thank you so much. We have one more question. Relative to physician and environmental scientist, what do you say the role of veterinarian in One Health approach beside the collaboration?
Oh, I think a lot. Well, if you are curious, and because you are saying medical doctors and environment, no? For example, I was involved in how to say it, in canine leishmaniasis project that was working on the lab, but then I have to review what is leishmaniasis and what is canine leishmaniasis and why it was prevalent in some part of Peru or why it's present in some part of Peru. And then obviously I have to talk with medical doctors and environment specialists saying, do you think leishmaniasis appear in some time or is in the whole year? For example, looking for prevalence, I will say. But for environment, and just taking the example of toxocariosis, again, we can have a great discussion or discussion in terms of curiosity, no? Like, do you think this climate change will enhance the prevalence of toxocariosis or other kind of parasites? That will be, I think the first thing is a lot of questions will arise, and those questions are an open door for you to have a conversation with other researchers in different areas.
Thank you so much for your answers. If somebody has another questions.
Dr. Veronica, someone has asked, and I think all the participants will agree, that if you could share your email address as well, maybe after the talk in the chat box. And so if any of you are too shy to ask your questions, or you have, you know, a question that comes to you after the talk, you can email Dr. Veronica separately.
Yes, please feel free. I just sent it, I think, to you, Shan, because it was
oh yes, don't worry. I will put it on the chat after this. So I think we have another question now that's just come in. So this is good. So the question is, I did my undergraduate thesis on leishmaniasis in dogs, and although I could only diagnose them by direct examination, visualizing the amestigotes. Do you know, Dr. Veronica, if diagnostic PCR kits used in dogs are available, or can you get them outside?
Actually, when I was doing that it was in 2015, we were looking for a diagnostic kit, but at the moment, I think there is not. Yes, which is Hadassah is a really, really interesting topic. Maybe I just can raise you one thing that I read two days ago, and my specialization is not leishmaniasis. It was just because a question arrived and then I looked at. It was that there were 3 articles that mentioned not only leishmaniasis in dogs, but the importance of climate change and also arthropods in leishmaniasis. So yes, I understand that the difficulty could be the diagnostic treat, or let's say the PCR, no? But in that time it was not available. We were working on that. Your research was in Cusco. Yes, super. So Hassad, maybe we can exchange communication, because I also have a veterinarian who is working in Cusco, not in leishmaniasis, in other parasites, and maybe I can connect you with him, or anything you can need. But no, in that time we didn't have the available PCR. We were working on that.
Thank you so much, Dr. Veronica. So what we'll do now is, if you still have questions for Dr. Veronica, and if you don't mind just sticking around for maybe 5-10 more minutes, Dr. Veronica, we can address any more questions that come through. But while we're waiting, what I can do is, I know a lot of you are asking for the link to mark your attendance for tonight. So Dr. Veronica, is it okay if I stop your screen sharing so I can share mine?
Yes. Yes, no problem.
Thank you. So while we wait for more questions to come in, if there's any, I've just put up the slide here. And so on the left, I know the link is a bit small. I think one of our organizing team members will put the link in the chat as well. And so this will take you to the Google form for today, or you can scan the QR code over there. And so this will count towards your attendance for this evening. I think one of the earlier questions from our previous presentation was asking about, how many males and how many females we have present tonight in relation to gender inequality and One Health. So part of the questionnaire over here, we actually collect your sort of demographic data on gender as well. So, this is something that's interesting to all of you. We can share it after the whole event, and that will be quite relevant and interesting to see, I think, as well. I also have up here on the right all different social media platforms. So, it'll be great if you could follow us on all of them, but just to keep up to date with not just this week's webinars, but all the future events that we do, just follow us on the social media platforms, and also, of course, all the other initiatives that Dr. Veronica mentioned in her presentation. So clearly there are lots of different opportunities for you to get involved, if you're interested in One Health, which I'm sure all of you are. So, choose your opportunities and join as many as you can. I think that's what Dr. Veronica's talk has shown. You can never join too many things, I think. But you will agree with me.
It's true.
Yeah. I'm not sure if any questions are coming in the chat still. I don't think so. You're happy to stick around, Dr. Veronica, but if you have to leave, you can, if any questions come in for you after this, we can email it to you separately.
Yes, sure.
or if our participants are happier to email you directly, you guys can do that as well.
Yes, please email me if you feel free to do it, and also to visit One Health Latin America and One Health Social Science Initiative, and also ISOHA, because as you can see, it was my interest to join. Who is interested in One Health and the ISOHA from the newsletter, as Cheryl said, I got this information, and I'm really value how I met, for example, this student in Nigeria, and then we are friends, and I'm really proud of how she has grown with her page. So I really think that you as a student have the motivation, the enthusiasm, and more technology than some others, and that is an advantage.
I completely agree with you, and thank you so much for being here with us tonight. I think the whole point of all these events is to do more networking, and I'm glad that, I think everyone else has learned a lot from your talk tonight and all the different opportunities they can be closely involved with. So thank you again for coming here and being here with us this evening.
Thank you, Sean. Thank you, Maria.
Thank you so much, Dr.
Thank you, Dr. Veronica. Just to add on as well, so another opportunity in which you can be involved with us at ISOHA, if you follow again us on our social media platforms, we have a call for journal submissions. So if you have written any articles or any sort of reviews related to any field in One Health and you would like to share it with the rest of the world, you can use ISOHA as a platform to do that. We have extended the deadline now to 25th of January, so that's about 2 weeks ago. So if you, not sure if Andreas is in the chat, but maybe he can put the link or the graphic to how you can submit the form or your submissions if you're interested. But otherwise, follow us on our social media platforms that you can see on the screen. So this concludes tonight's session for this week's conference. Tomorrow, we will have Dr. Sarah Savage, who will be presenting. Her title is One Health Education, Where Do We Stand With That and Where Should We Go? So it promises to be, again, another exciting talk. And I hope if you've enjoyed yourself tonight, you will come again tomorrow and for the rest of the week. So we will start at 7 p.m. in Romanian time. So that is GMT +2. We will send out the link again to the Zoom meeting shortly after this. So keep a lookout for that for tomorrow's meeting. But otherwise, thank you so much for coming here this evening, and we are very happy to have all of you here with us again. I will keep this slide up and this Zoom meeting open for another 10 to 15 minutes. So use the remaining time to fill out the form to register your attendance. The link will close in about 15 to 20 minutes. So just make sure you do that before you leave. And we hope to see you all tomorrow. Thank you all for coming.